Good morning, and thank you for joining the Collaborative's October monthly webinar. We're going to give everyone just a couple more seconds to settle in, and we'll get started shortly.
Unmute. Good morning, Maria.
Hey, Janie. We're going to get started in just a second.
No problem.
Awesome. Well, just a couple of housekeeping reminders before we jump into the formal agenda. Participants will be muted during the panel discussion to limit background noise and interruption. However, we're saving ample time towards the end of the agenda to hear from you. So to engage with the panel, please use the raise hand icon on your toolbar, or you can submit written questions and comments via the Q&A feature. Also, please note that this webinar is being recorded. You can find the archived recording on the California Collaborative's materials page, and we'll also send a highlights email next week that will include the link. Our agenda today is focused on a deep dive conversation around LTSS workforce challenges, considerations, and opportunities. As you may already know, California is embracing a demographic shift. Our older adult and disabled population is projected to diversify and grow faster than any other age group. In the next 10 years, over 1/4 of Californians, or roughly 10.8 million individuals, will be 60 years of age or older. And as the number of older adults and people with disabilities grows, long-standing workforce challenges are rising to the forefront. By 2030, it's estimated that California will be grappling with a critical 3.5 million caregiver shortage. The Master Plan for Aging, which was released earlier this year, cites challenges with income. Roughly 1/4 of direct care workers earn less than half of California's median annual income, and 1/4 fall below the federal poverty line. It also cites stress and an elevated risk of job-related injury. So today we have invited a diverse group of collaborative members and guests to engage in a conversation about these critical considerations for addressing LTSS workforce challenges. So without further ado, I'd like to welcome Elizabeth Evanson, Policy Director at Chapman Consulting, and Elizabeth will be serving as the moderator of our panel today.
Everybody. Thank you, Maria, for the introduction and for joining us this morning. I wanted to introduce the panel members briefly, and then we'll get into the discussion. First, we have Pat Blaisdell, who is the Vice President of Policy at the California Hospital Association. Pat has over 20 years of experience in hospital and healthcare management in both acute and post-acute settings, and particular expertise in post-acute reimbursement and clinical operations across the continuum of care. Kathleen Kelly is the Executive Director of Family Caregiver Alliance, a national nonprofit organization that provides direct caregiver support services, public policy development, research, and public awareness regarding family caregivers. Kathleen oversees programs of the Bay Area Caregivers Resource Center, California Policy Collaborations, and the National Center on Caregiving. Next, we have Dr. Vanessa Tatum, who is on the board of the California Association for Adult Day Services. CADS is a statewide association that supports the development of adult day services and an alternative to institutional care. CADS is the oldest and largest state association of adult day services in the nation. Membership includes centers that provide day programs that support individuals with physical, mental, or developmental disabilities and older adults with Alzheimer's disease, as well as their families. Janie Whiteford is the president of the California In-Home Supportive Services Consumer Alliance.
Coast Customer Service.
Sorry? Does somebody need to mute maybe? CICA for short is a statewide coalition of IHSS advisory committee and governing board members representing the consumer viewpoint on IHSS issues at the local, state, and federal levels. And finally, we have Brandy Wolf is the policy and research director at SEIU that's a mouthful, huh? SEIU Local 2015, which represents over 385,000 home care, skilled nursing facility, and assisted living center workers. Local 2015 is the largest in California and the second largest in the nation. Maria, we want to let the panelists say a couple words, or we just jump right into the conversation, yeah?
I think we'll just jump right in. So we'll stop screen share and then we'll bring up our panelists.
Okay, great. Thank you. Our first question we have for all the panelists is the master plan for aging cites low wages, job stress, and elevated risk of injury as the driving forces behind a shortage of caregivers in California. From your perspective, what are the key challenges that have resulted in a shortage of caregivers for the state's older adult and disabled population?
I'm happy to start. This is Brandy. I don't know if we have a particular order that we want to go in, Maria or Elizabeth, but I don't know that anything I'm going to say here is going to come as a surprise in terms of an answer to this question. I think there have been a number of factors that are impacting the workforce shortage. I think the environment that we're operating in currently, I won't say post-COVID, kind of in the COVID environment, is every sector of work nearly is experiencing just a general workforce shortage currently. So I think that is only exacerbating existing problems in workforce shortage within the LTSS industries. But then also COVID itself has sort of knocked the door down and exposed some of the major issues and inadequacies in the LTSS system in terms of protections, not only for the consumers of the services, but also for the workers. I think some of the issues cited within the question itself are the major players. As an individual representing the workers on the union side, low wages and benefits, no access to paid time off. IHSS providers are still not at the full 3 days of sick leave that other workers in the state are entitled to. As Maria mentioned, shifting demographics just in the overall population. People are having children later or not having children at all. And so particularly in the IHSS system, where we see that roughly 70% are family care providers, that demographic is going to shift with the reduced supply of family caregivers that can provide those services. So I think that those are probably, from my perspective, some of the biggest factors. And again, from the union perspective, looking at the fact that in many counties, IHSS is a minimum wage job. In nursing facilities, the average pay statewide is not much higher than that. And it is very difficult work, both physically and emotionally, for very little pay. So I would offer that those are probably what we see as the biggest issues addressing the workforce shortage.
Thanks, Brandy.
I'd like to add that some of the additional challenges is that what we're seeing, Brandy alluded to previously, that the IHSS workforce of family caregivers is gradually aging out, and that supply will be less. A lot of times siblings have their own lives, their own jobs and occupations, and they're not going to continue to provide care that perhaps older caregivers did for perhaps their disabled adult children who had congenital or developmental or intellectual disabilities. These people are now having to find caregivers from agencies or outside the IHSS system of family caregivers. In addition to that, what we're finding is previously there were a sort of a spiritual, if you will, mission or desire to serve that would drive people into the fields of nursing and caregiving in general. and people who had a heart to provide care, good, excellent care to people who are ill or disabled or otherwise challenged, that group of workers is starting to diminish for lots of reasons that COVID really brought out. They realized that that particular field of endeavor, that occupation, is full of dangers. They were fearful of their lives, of bringing things into their own homes if they lived at home with small children, babies, or elderly parents or relatives themselves. They felt unsafe for the first time to go to work and to come back home. Some of the skilled nursing facilities met the challenges of COVID by trying to offer things such as hotel quarantining before you returned home, but that didn't address the main issue. It still separated them from their households for 2 weeks or something at a time. And even if you were being paid the 2 weeks, you're outside of your house, and the impact of that long term, I think we're not even sure what that's going to look like as we see what happens to children or to other family members that were separated from parents or caregivers. So this is the master plan on aging about what do we do about a group, a workforce, if you will, to help as Californians start to age, is only exacerbated by the now, I think we're going to see a significant decline in people who are going to choose healthcare or caregiving as a viable, respectful job opportunity.
Tatum, anybody else like to share their perspectives before we move to the next question? Okay. So this, next we have a question that we're going to direct to Pat, Janie, and Dr. Tatum, and that it has to do with California's geography and it's being a large and diverse state. What are the unique workforce challenges in the urban, rural, and frontier areas that should be taken into consideration as stakeholders, legislators, state leaders, and others look to bolster California's LTSS workforce?
Yeah, this is Pat Blaisdell from the Hospital Association, and I want to echo some of what Dr. Tatum just said on this issue, that I think the COVID pandemic has placed such stress on the system that we're really becoming very aware of the stresses it's placed on both our clinical and our non-clinical staff. Certainly within the Hospital Association, a lot of what we've talked about and focused on is the need to bolster our bedside nursing staff, and as well as staff in other levels of the care continuum. But it has also, if the pandemic has done anything, it's really taught us how interdependent we are on caregivers at all levels of care. Individuals that come into the hospital are cared for by clinical folks, but ideally they go home and they get cared for by family members or other caregivers. And I think the pandemic has really showed how both of those components need special attention and special care to ensure that you can't do one without the other, basically, is what it boils down to. I think when we talk about different parts of the state and different communities, I don't know if the issues are different in different areas, but certainly how they play out and their impact is quite different, particularly focused on our challenges in the rural communities, where overall any kind of workforce is often stressed just by being able to recruit to that locale for some specialty areas, and also by the increased kind of distance and isolation that might affect people being able to get to and from the home settings. I am particularly focused on things like the ability for the local healthcare providers to provide support to caregivers, either through home health or through making sure that the caregivers have adequate support and information and access for the kinds of support they might need to provide ongoing care. So I think that one of the things that happens in the rural area is that everything in terms of shortages becomes that much more acute. And it is exacerbated by the distance that sometimes folks are from any center where they could easily access support. And also, I think that it adds some greater concerns to the level of isolation that some elders and folks with disabilities might have in these rural areas. I do think that we've learned a lot about how to use telehealth to provide that support, and I hope that we're able to continue to do that, not only from the standpoint of doing telehealth and doing physician visits or whatever remotely, but being able to provide support to caregivers as well when they're at some distance and need information and support.
This is Janie. I would like to echo what you said about the rural areas. We're seeing in Sika with many of our folks that it's very, very difficult to find in the rural areas providers because they're just, the population is so much less. You just don't have that much to draw on. So that has become a very great problem. Another issue is the remoteness of so many people. I mean, I know folks that, they say I have a provider, but she has to travel 45 minutes to get to me. So that travel time is a huge issue for a lot of folks that need this help. If it's a family care provider, this is not as acute a problem. But in the rural areas, if you have to get somebody from the outside that's not a family care provider, it can be a huge issue. Also, those that work in this field, that you see it as their job, going in the rural areas, going from one consumer to the next consumer can take an hour, so that's a huge issue. So when we're looking at how do we solve this problem, I think you really have to look at in the rural areas travel time, because that really takes, to not be able to, and gas, my gosh, right now gas is so expensive. So that's a huge issue. Also in the rural areas, you don't, as Pat said, you don't have the supports. I know the ILCs, say we have all these programs, the public authorities have programs, but when you have to travel an hour to get to them, that's an issue. And people are not going to do that. So I think that when we use, as we're doing today, telesupports, that can be a huge help. And we need to really look at how we can make that more available to folks. Again, in the rural areas, we have a lot of people that are very low income, and unfortunately, they might not have the telecommunication abilities to actually, utilize these opportunities. So that again is another issue that we might have to look at, and so giving them some kind of help, having once they come on board with IHSS, that they have that telecommunication ability in their homes. As far as the urban areas are concerned, or suburban areas, we are finding here, I'm in the Bay Area in Santa Clara County, we're finding it excruciatingly hard to get folks because of the how much they're making. It is, you can go to McDonald's here in the Bay Area and make $20 an hour. Nobody in home care is making that. So that in itself is a huge barrier. And we really have to look at some way, as Brandy said, bringing that salary up, that salary level up. It has to come up, and the benefits have to come up too. That to me is probably the greatest thing.
Hi, this is Dr. Tatum, and I echo what Janie and Pat were saying: the salaries, the driving distance, the transportation, and the scarcity of those support systems that we need to help people age gracefully and safely and in a healthy fashion in their own homes. I'm finding that that exists in a lot of little pockets of urban areas as well as some of our rural areas. I'm here in Orange County in Southern California, and I happen to be located in an area that is surrounded with lots of wealth from Disneyland and the beach resort communities. So there are many resources available here. But if I take a 30-minute drive north of us and I enter the Inland Empire, Riverside County, I'm going out to Palm Springs or to the desert areas, Beaumont, Manning, it's spread out such great distances from hospitals or adult day health cares that I cannot find support for patients or consumers that need things like home health. It's a challenge for me to order oxygen for people, Hoyer lifts. There's just a scarcity of providers that want to drive out there to deliver the things, to service the things that we often take for granted. Meals on Wheels, even in urban areas. There are little pockets here in Southern California, Compton, Watts, some of the areas that have historically been associated with higher crime or violence. There are little pockets of elderly people who brought their homes in 1950 or 1960 that are stuck there and need resources to live there. And we cannot, our social workers have had a difficult time even arranging Meals on Wheels. No one goes there. So we're having to try to be creative and asking local churches if they would, since they have full functioning kitchens, if they'd be interested in applying for these state and federal programs to provide meals as a source of incomes for their local churches. So we're having to try to be creative to see if we can make sources where no sources exist. And it is a real challenge for all of us. And we're going to find that as time goes on over the next 10 years or so, this is going to become an increasing problem where there's pockets of people stuck in suburban areas where there are no service providers, not only for hands-on things you need, but for things such as food or sustenance.
Dr. Tatum, Janie, and Pat. And I saw somebody pop up in the chat pointing out too that in the rural areas, access to internet, it can be a real challenge as well, which is another layer that's complicating things there for telehealth and addressing the digital divide. Let me pull up my questions again. The next question, how has the COVID-19 pandemic impacted the workforce? We talked about this a little bit, but if anybody has any lessons learned or best practices that can be maintained moving forward, maybe that's an area where we could look to offer some supports as well. Brandy, Kathy, or Dr. Tatum, would one of you like to address this question?
Well, this is Dr. Tatum. I'd like to say, I think Pat and Janie kind of refer to it, and Brandy deals with a lot of the union workers, so I'm sure this comes up. What we'll have to do in our healthcare area is I'm having to be more creative in terms of recruitment for staff, because as alluded to previously, we're competing not against other healthcare workers, but we're competing against all industries because, as they mentioned previously, a person could work at McDonald's or In-N-Out Burger or Amazon or FedEx and get a higher salary, hourly salary, and not have to change diapers or do transfers or anything like that. They can just go and sort packages and make the same amount of money. So what we have to do as an industry, trying to recruit and compete in that market, if you will, of recruiting individuals to work, is maybe not try to go dollar for dollar for them, because we can't. Obviously, we can't pay $20 an hour for a caregiver. So I think what we're going to have to do is be creative in terms of perhaps offering things such as touting our job flexible hours. and that we have available full-time hours, which is McDonald's and Amazon and FedEx. They're not going to give full-time hours because they don't want to provide benefits. We may also, as employers, need to add things that we previously didn't add in order to recruit and retain employees, such as participating in retirement funds, either the state-sponsored retirement or private. So flexible hours, retirement, offering perhaps continuing education or some kind of state certification. Some of those things we can do at little or no cost in terms of continuing education. We have resources that we're already paying for. If you have, I know at the California Hospital Association and some of the skilled nursing facilities, you already have consultants like here. I'm a director and administrator of an adult day healthcare. We have consultants, physical therapists, occupational therapists. They could teach classes and have continuing education in that respect. I'm already paying registered nurses. They can teach some of the classes. So we're going to have to get creative in terms of recruiting people. Perhaps we'll have to partner with local high schools or regional occupational programs to get people who want to be trained as CNAs to be caregivers. And so we can offer on-the-job training, tuition supplement, and then they give us a year of guaranteed employment, you know, for every year of tuition. We just are going to have to be increasingly creative as to what constitutes a benefit. And I know Brandy may have a little argument with me about that, because I know union workers usually like to think of a benefit as, you know, more money and more health benefits. But I think if I'm giving education, transportation allowances, one of my RNs, I had to recruit from a neighboring county. The company pays for her fast track and we give her a gas allowance. So you're going to have to be very, very, very creative in terms of just trying to offer that as a benefit to recruit people.
This is Janie. I just wanted to say here in Santa Clara County, we offer our contract just got renewed, and we're going up $1 next year and $1 the following year. So the 2 years will be up to $17.50. But 15, yeah, that's right. And we also offer really good medical benefits, vision, eye, dental, and you know, regular good benefits. And we also give them an Echo Pass, which is a county pass for transportation. We still have trouble getting folks. What we find a lot is that folks will come in and they'll be an IHSS worker for the amount of hours. It's only 35 hours a month that you have to work to be eligible for our medical benefits or all the benefits that we have. So they'll work for that amount, those hours, and then they'll go out to private pay. And here in the Bay Area, private pay is, because I have to do this, is $30 an hour. That's just about where the base pay is for private pay. That's a whole other issue that I think we have to look at. Are those that are not IHSS, that are in the gray area, that or above that are paying, you know, a tremendous amount of money out of their income for home care.
So this is Kathy, and I'd like to address some of the issues from a slightly different perspective, and that's from the unpaid family caregiver perspective during COVID and lessons learned. And that is that if families were using either in-home care or daycare programs, they lost those opportunities for any sort of substitute care during that time. The other piece around families that are caring for someone in the home is that during that time, it's kind of hard now to remember because we have to go back to the beginning to think about our frame of mind during the first year of COVID. But that was that not only did you lose any sort of contact with people, staff coming into the home or going to daycare programs, you also lost your other visitor stream of, it could be friends or neighbors or other family members, because people weren't going in and out of everyone's home, if you remember, to have a visit. So there were literally, since most family caregivers live with the person that they're caring for, they were literally isolated for months at a time. It was just them. There wasn't anyone coming in or coming out. Maybe food was delivered, those kinds. Maybe there was, someone standing 16 feet away, talking them through the door. But it was all very limited during that initial period of time. And the communication about the services, this was the lesson that I observed. We have, I sit in San Francisco, but we serve a regional 6 Bay Area counties. And what I think that we do need to think about and improve is the central points of information that need to be put together, excuse me, during these emergency situations, not 211. I'm talking about what counties, all of the folks that are providers within the county, to be apprised of the changes that are going on throughout the course of the pandemic. There was, what I saw is not exactly good communication or centralized communication about who was open, who wasn't, who had food, who didn't. I mean, really and truly, there's a lot of improvement to be made in emergency or extended emergency situations, which I think we can all count on having for those of us who live in this hardy state, regardless of whether it's a flash flood, a fire, an earthquake, or a pandemic. Emergency situations and ongoing communication is really important. There was a loss of visitation, of course, in nursing homes for family caregivers. So the flip side happened. But I think the other observation is that, a lot of the direct care personal aides that were going in and out go in and out of multiple homes, in and out of multiple facilities. And this is just one more issue around disease spread and so on. And then of course, the lack of PPE, in the initial stages of the pandemic. I do want to make a comment parenthetically about the telehealth issue. California has received $3 billion in telehealth. They're allotted $3 billion to solve the telehealth issue problem. And so I might humbly suggest that you have someone to come in and talk about what's being proactively done in terms of solving the digital divide, because there are resources available to do this, either from the state perspective or someone like from the Center for Connected Health, who tracks telehealth policies in the state. Because it comes up almost at every meeting that I hear, but everyone notes that there's a problem. No one knows what's being done to solve it. So I would suggest that maybe a speaker come and talk at a later point about how this problem is being addressed now.
Yeah, thanks, Kathy. Good point. And your points on the, social isolation and people being afraid to visit each other in the early stages of the pandemic are a pretty good segue to our next question, which is, how do you see the medical and social models working effectively in the delivery of LTSS? And we have that one is we can start with Pat and then on to Brandy. Thank you.
Yeah, thank you. This is one of my favorite topics. I think we think of the medical model and the social model as often two different things, and they're very different philosophy of care. And yet I think we also need to recognize that they aren't mutually exclusive, that there needs to be an overlap between them. The medical model needs to support the social model and so on and so forth. After all, many folks, almost all of us are going to be a patient at some point in time. And the idea is to transition that person from being a patient to being a consumer or a resident. So I think we have a lot of work to do in trying to help the medical model and the social model integrate to really support that transition in an effective way. I'll acknowledge that hospitals are very much set up to treat diseases. They do things to people to, in their view, make them better. But it's around a disease model that there's something about this person that we're going to fix. Thankfully, hospitals are also, many, if not most of them, conduct additional services that are designed to support care transitions and getting from the acute hospital setting to a more community-based setting. But it's something that we're really challenged by. My own background in the area of post-acute care really has tuned me into the need to be moving from that medical model to a model where we're paying less attention to disease issues, to disease trajectories, all very important. We got to treat the disease or do the surgery or whatever, but greater attention on individual goals for the residents and consumers that we're caring for, and toward independence. As a former rehabber, we like to say that, yes, we have to treat the problem over here in the hospital, but we also need to treat the individual person with the problem, to work on their mobility, their ability to dress themselves, their ability to get a meal. And I think that's where the integration of the medical model and the social model become particularly important. We haven't paid enough attention to how to translate and focus on functional activities and a patient's goals for independence as a primary outcome goal of the care that we provide. Happily, I think this is changing somewhat. In many hospital and medical care settings, there is a greater focus on functional status, mobility, and patient goals, a greater move toward age-friendly care, a greater attention to patient, resident, consumer choice. Although I think it's going to continue to be a challenge for us to work on that. In addition to kind of the philosophical difference of what happens in a patient care setting versus a community consumer-based framework, I think there's a lot more that we can do to facilitate caregiver training and support throughout the continuum of care. It's not something that can happen at the point of discharge at the hospital only. Obviously, when someone's being transitioned or discharged from the hospital, there needs to be information and support to help them make that transition. But we need to also provide for that ongoing support and care so that once somebody leaves an institutional setting and is in a community setting, they continue to get the care that they need. I think one thing the pandemic has done is really accelerated the interest in all kinds of home-based care, home health, community-based care, remote patient monitoring, as they'll say, some of the things that come into telehealth, as well as even hospital at home or long-term care at home type options. So I think these are all things that have been sort of, clicking along a little bit, but I think the pandemic has really allowed some of that, the interest in those things to come to the forefront. So want to hear what some of my colleagues have to say about this, but I think the medical and the social model are not mutually exclusive. We all need to recognize that and work on ways to integrate the transitions between the two levels, the two philosophies of care, and support an individual patient or consumer's needs in whatever level of care they're at. So an area that I'm particularly focused on and really welcome the opportunity to work with all of you in that arena.
Yeah, I mean, in the interest of time, I don't want to duplicate what Pat has said. I actually wrote in my notes something similar. I mean, the social and medical models don't necessarily have to be adversarial to one another. I think we just need to be thinking creatively and innovatively about how the two aren't adversaries. So, I think for folks on this webinar who have worked with me, that when I talk about the CCI, it brings up a lot of emotions for all of us, but I think we really have lived and learned through that process about what does and does not work. And so taking some of those lessons learned and moving them forward about what we should and shouldn't be doing. I think at the root of the social model is consumer direction. And from our perspective, that's incredibly important to maintain. But how are we working together in some non-traditional partnerships that maybe haven't taken place historically, to meld the two in a way that meets the needs of the consumers, patients, residents? So that's what I would add.
Thanks, Brandy. So speaking of the social and medical model, we can't really talk about support for older adults and people with disabilities without talking about their caregivers, and how do family caregivers fit into the LTSS delivery system, and how can the system better recognize their role?
Yes, I've been asked to start off the conversation here, and I just wanted to set a little bit of a context. What I'm going to give to you is that we talk about family caregivers, but we don't really talk about who they are and what they do. Very often we just talk in generalities. And so I want to set a context for this, because I'm going to give you some statistics and findings from a second year report, an evaluation report's been done by University of California, Davis, with our research team there, to look at the issues that have been surfacing in the uniform caregiver assessment that we do across the state within the caregiver resource centers. So you're getting hot off the press earlier than anybody else has ever heard these statistics before, because they are a little bit sobering. So just to set a context, 2 years ago in 2019, when everyone was, we were going forward for augmentation requests all over the place, we did receive a 3-year augmentation request that was memorialized last year to essentially expand the caregiver resource center system to actually make it whole from the cuts that happened during the recession. But also to install a new front-facing HIPAA-compliant interactive client record called CareNav. And embedded in CareNav is a uniform caregiver assessment. And so I'm going to speak to some of the issues that came up in the uniform assessment in just a minute. When we talk about family caregivers, the 4.7 million estimated family caregivers that are really providing the bulk of LTSS in the state. We know something about caregivers more recently because we look at the state data that's collected through CHIS, and then we also look at the national data that's collected through the caregiving in the US by AARP and NAC. But what we're finding is that the data that's in these panel studies or random dial in the case of CHIS is that they reflect a caregiving population that is not as, that's a lower risk than the population that actually services when they come to the CRC for services. So who are we talking about? The individuals that self-identify or referred to receive services from the CRCs are 75% women. 61% of them are under the age of 65. 48% of this particular sample is non-white, and mostly they're adult children who are providing care. When we talk about the kinds of services or support, it's going to be more complex and intense care than we normally associate. In fact, to the extent where we're going to be doing a little bit more of a deeper dive on the complexity of care. So 90% have a high level of care, and this is actually an algorithm that's based on weekly care hours, number of ADLs and IADL supports. So just to step back for a moment, the CRCs were set up to serve all Californians regardless of income. So we have a middle income population, and 25% of the care recipient population, the caregivers are also on Medi-Cal eligibles. So we have a wide range of incomes when we're talking about the caregiver experience in this. We also know that 78% of the, and they're caring for adult onset cognitive impairments. We have other contracts that are just for physical impairments, but what actually this population represents are multiple chronic healthcare conditions with an overlay of cognitive impairment. That's 90% of the population. So 90% provide high level of care for this particular population. 78%, because we ask medical tasks, what specific medical tasks are they doing in the home, because they're allowed to do it. 78% are doing one or more medical tasks. The 73% spend more than 40 hours a week. In fact, most live with the person they're caring for, so it's pretty much a 24/7 situation. 70% have no paid help whatsoever, and 40% do not receive, 70% have no paid help, and 40% have no help from family and friends. In other words, unpaid help coming into the home. So this is a pretty high risk care situation that really there's one caregiver who's pretty much doing it all. Within the past 6 months, we asked about healthcare. 35% reported their health as worse. 20% have moderate to severe depressive symptoms as experienced on the PHQ-9. 35% say they are lonely, and we use the UCLA scale for that. About 10% have dropped out of the workforce that I can see. We have had in the past annual reports and data across the CRC system, and we've typically had about 48% of the caregivers also participate in the workforce. That's dropped to 37%. So what does this mean for a policy implication? There's the obvious lost wages, loss of benefits, loss of Social Security credit accrual for retirement, loss of contributions to retirement accounts, and loss of skills and job availability, as the time is prolonged in their caregiving role, reentry to the workforce gets much more difficult as well. So we have this population that is quite distressed, is quite isolated, is performing very intense caregiving tasks and with very little support. So, you can move the policy needle going forward. We do provide, respite support that's consumer directed. They can choose, families can choose whether they want in-home, out-of-home, temporary, care in daycare programs. So they have the gamut of what they can choose for respite, but it's not enough on a consistent basis, particularly for middle income individuals, to afford care, as everyone has talked about, the kind of care on a per hourly basis, either for private care or through an agency. You can see that it adds up pretty quickly. And we do encourage, participation in daycare programs as well. But, the fact of the matter is that many of these caregivers are providing unrelenting care for long periods of time without a respite and substitute care. So I'll stop there. I think I've given you enough statistics for a Friday morning.
Thanks, Kathy. It looks like a lot of people are eager to get their hands on that report. Sounds like there's a lot of good information in there. Dr. Vanessa or Janie, would you like to add anything to what Kathy said?
This is Janie. I just want to say that in IHSS, we know that they're 70% are family care providers. I don't know if in the statistics have anything about ethnic breakdown of family care providers. I think that would be interesting to see, because I know that when I was doing trainings with consumers, that the depending on what the ethnicity was, that there were, that especially in the Filipino, the Asian community, that they felt that it was a family duty to perform these, and they would never ever go outside unless it was a real issue to get someone other than a family care provider. I'm kind of wondering as these folks age and the kids age, whether, and they become more Americanized, whether they're going to see a change in that philosophy and then be needing more care providers from, that they would be willing to actually hire. Yeah, it's a really, and I also look at the DD population, all those folks that have been caring for their children for years and years and years, and then they get older, and then what happens? That's a huge issue, I think, that I know the regional centers have to deal with, and that's another issue that I think we need to look at, and getting the help that those folks need. Again, with the DD population, I've always been really concerned, and I know Parents Helping Parents have too, with getting parents to realize that they need to reach out and get additional help, because they're not going to be able to do it forever. And what happens after they can no longer care for their loved ones. That's it.
Hi, this is Dr. Tatum. Kathleen, that was excellent. And I was taking notes, and I'm looking forward to seeing the final report as well. Janie, I actually work with the DD population and closely with the regional center, our adult day healthcare center that I'm the administrator of. We specialize in providing services for those that are developmentally disabled. And that is a big problem. And what we're finding is that the next generations, the siblings, if you will, are for the most part not willing to do the same things that their parents did. And the regional center is aware of that, and the Department of Developmental Services here in California, I think, have put together a kind of a pretty good program where the service coordinators or case management people for the clients are introducing the idea to the family members that are aging or with ill health, that they should start interviewing or visiting licensed residential group homes that might serve as a new residence for their son or daughter as they become unable to provide those services, or after they pass on, if there are not other siblings that want to take on that task of having that individual live in the home or them move into the home with them to do that. But we are going to see a bigger need for these licensed residential group homes, because right now the system is quite full. So RFPs or requests for proposals are always sent out for these licensed group homes. And those become a challenge to establish because of the previous topics that we just mentioned. Staffing, that's the main thing. Workforce, you need to have a workforce that will operate the homes, which require 24-hour staff, registered nurses if they're developmentally disabled nursing homes. They're called DDN group homes with 6 people. So you'll have to have RNs, LVNs. There's just a variety of licensed required specialists and consultants who have to either design or supervise services. So these other populations that we're going to see have greater needs, both for supports in their own private homes as well as for a licensed group home. It all goes back again to the workforce. This is, I've never seen such an impact before on workforce as we're seeing now.
And you know, Janie's comments on families, you know, historically having played a large role in caregiving is a good lead into our next question, which is, you know, what are some good strategies for not only expanding but also diversifying the workforce to ensure that caregivers are culturally and ethnically diverse, mirror the background or mirror the population they serve, and provide care that reflects the consumer's background?
So I think there's some sort of low hanging fruit, I would say, here on this question, just at a very basic level. Right now in IHSS, there is only the core, the 4 core competency or core languages. That does not expand enough, and there is no data captured at the state level for provider preference in language. And so at the union, we run our meetings and produce all of our materials in 11 different languages. I know, for example, LA County chooses to go above and beyond the 4 core languages that the state requires to meet the language needs of their provider and consumer population in LA County, but that's not the case statewide. So, you know, that's just one example of a very basic fix that could be made to help both providers and consumers communicate in their preferred language to learn about the program and what it takes to be a provider and eligibility as a consumer and all of that. You know, I think cultural competency training as well. We have a real opportunity with the IHSS learning pathways, the $295 million investment in the various learning pathways, to really think about how training is done in a culturally competent manner. I know that Janie has raised issues in different venues around the need for access to consumer training as well, ensuring that that is done in a culturally competent manner. I think those are some of the very, in my opinion, simplistic things that we can do. On the nursing home side, you know, another example of this is that the CNA exam is only available in English. The materials, and the exam itself are only in English. While we understand the need for a CNA to be able to chart and document in English, you know, being able to take a test in a language that is your preferred first language, we think is a simple fix. We've had conversations with CDPH about this, you know, and want to move forward. But those are just some very simple things to ensure that individuals who are looking to get into the workforce are able to do so in a way that they understand the program and the requirements and all of that in the language that they feel most comfortable learning in. So I think that's a place for us to start, but I'd love to hear what Janie has to offer.
Thanks, Brandy. Yes, it's a huge issue. I know here in Santa Clara County, we reach out continually to the Asian community, to our Hispanic community, to our Russian community, to get folks that speak both English and that language, that are bilingual. And it's a tough nut to crack. It really is difficult to get those folks on board. We sometimes will offer incentives to other providers, that if you know somebody that wants to come in and they actually become a provider, we'll give them some kind of an incentive to do that. So there are different strategies that we are using now. But on the issue of multiple English translations in other languages, that is incredibly expensive. And I know that a lot of the public authorities would love to do that, but they just don't have the funding to reach out in all those different languages and print form to give their providers the information in different languages. Those counties that have that ability, like LA, we do that here in Santa Clara. We have additional funding, but throughout the state, it's not the norm. So I think that would be helpful too. It's a very difficult issue to crack, and I think training wise here, we do provide training in Mandarin, in Vietnamese, and in Spanish and English. So we have a very robust training program that we were able to develop in coordination with the union. We have SEIU here in Santa Clara County, and that's been very successful. So and our providers that do participate in the training programs do get a stipend once they've completed that program. So that's another dual incentive to get folks to come for the training. I know we're looking at developing training here in the state. What that looks like is we have absolutely no idea yet. But some of these, and I think a stipend for that would be absolutely necessary to get folks to participate in that once we develop that module.
Can I just make a comment about a different segment of the workforce that supports the LTSS? And that is, I don't think we're graduating or attracting or providing incentives for persons of color to enroll in social work programs. There's a really huge shortage. We talk a lot about aides, we talk a lot about nurses. We do not talk about social workers, and social workers are sometimes the connective tissue between the community and the medical system. They're certainly incorporated in many of the LTSS settings, but we do not provide the incentives or training, and so few of the social work curriculum have anything on aging at all. It's really geared towards children's services, not making a criticism of that, but UC Berkeley used to have a track for persons interested in aging as a social work program. They don't have any students. So while we're thinking about this, what happens is that social workers come to us. They have a good set of generalized skills, but it takes a 6 to 9 month training and supervision to get them geared up on basic aging issues, working with family dynamics, and all of the different conditions that we have to deal with, as well as the legal, financial, all the different things that we're working with. And by default, we're doing a secondary graduate school training within across the CRCs. So we don't talk about this very often, but it is really a deficit. We need to provide and create some incentives for people, for particularly bilingual, bicultural students to go into social work, and we need to elevate the status of the social work staff in general across all these sites of employment.
I absolutely agree with you, Kathleen. This is Dr. Tatum. We spend a lot of time and incentives and training all of our social workers at our adult day health program, because when they come to us, they all have master's degrees, but I have to, myself, my nurse, my PhD consultant, we have to train all of them in geriatrics and medical social work, so that by the time they finished a year of working at our facility, they are excellent medical social workers. They can do forensics, they can look for signs of neglect and abuse, they know how to resource goods and services, they know how to do care coordination and case management, they can get hospital beds, oxygen meals, they know how to do everything, but that's additional training we have to pour into them that they did not get despite being graduates of some very fine universities.
Yep. Yep. And, for those of us who are in community-based organizations, we train them up, and then the hospitals and the counties, employ them for, a third more salary than you can pay at a CBO level. So I'm just saying, and I just sorry to rag on this, but when we've supervised a number of our staff and others for their LCSW exams. And when they come back, they go, well, we got 2 questions around aging and everything else was around kids. So at the LCSW, at the highest level of practice, there's not an emphasis on aging issues either. So just saying.
Thank you for your perspectives. I think I might just wrap us up here because we have about just a couple minutes left for this conversation, and then I think we wanted to get to Q&A. So I think we've heard a lot about some of the challenges and some potential ways to address those challenges through attracting a diverse workforce and ways to get around language barriers and making sure that the workforce or trying to get the workforce to be a more reflective of California's ethnically and culturally diverse background, which is great. And I just wanted to give folks maybe 2 minutes apiece to mind if you share a couple, or sorry, if you wanted to discuss, any last minute thoughts or perspectives on addressing the workforce shortage.
Yeah. This is Janie. I just wanted to quickly say something about, Pat had talked about and Brandy, the social model as opposed to the medical model. And I think I really want to talk about, and Brandy mentioned it, consumer education. And I think it needs to come from within the medical model all the way down to the social model. I know that nobody, I think in a lot of our programs, the consumers don't know what the program gives them and offers them. I'm a huge proponent on requiring in IHSS consumers at least look at one video that explains what IHS is and what it provides and what it does not provide. Because I think we get so often consumers getting in trouble, losing their providers because they expect more than the program can give them. I also think that people are not born managers a lot of times. And it really is important for those case managers in the hospital, for those social workers in IHSS, to kind of go over what it takes to be a good manager, what it takes to be in a symbiotic relationship that benefits both the consumer and the provider. We see a huge churning in a population in IHSS of folks that just go one provider after another provider after another provider, where interventions have to be made. And a lot of this is because folks just don't understand the process of what it's like to have that relationship be successful, what you can and cannot do. So I just wanted to mention consumer control is important, but it comes with a caveat that the consumers do need that piece of education and training. And some way it's got to come from all of us.
Yeah, thank you. I think that's a really important point.
Yeah, I mean, I think I would just wrap up, in looking at some of the questions that have been posed to us that we're, kind of condensing into this last couple of minutes. I think this year I'm one of the newer, I would say newer people, even at a decade of doing this work, newer to the LTSS world. And, I think we've had an incredible year in my short tenure. Legislative and budget cycle, we saw some real investment in LTSS in the way that we have not in at least in the time that I've been here. But I think right now, what is so important for all of us that are on this webinar, that are part of this community, is to ensure implementation and continued investment. Yes, the $295 million for learning pathways is incredible. It is more investment than we have seen, but it is one-time funding, and the state is treating it as such. And so how are we making sure as advocates that we are setting ourselves up for continued investment and continually demonstrating the dignity of this workforce and this consumer population and the need for investment in that. And I was a part of the master plan process. I'm very proud of that. But what I will say is the master plan is a framework, and any framework can sit on any shelf if it is not being implemented and being invested in. So I'm very proud of the framework that many of the people on this webinar helped to put together. But unless we are the tireless warriors trying to fight for implementation of these policies, it's going to collect dust. So I think everyone has done an incredible job thus far. I just am very eager to continue with the passion to get these policies implemented over the next several years.
Yeah, I agree with all that Brandy has said. In terms of kind of basic strategies to move the workforce issues forward, a couple of thoughts. Obviously, there's short and long-term goals. I mean, obviously, we need to, each of us as providers, need to look at how we are recruiting, where we're recruiting, and what kind of work experience we give folks once they come on board. I particularly like Dr. Tatum's discussions around using one kind of staff to train the other. I think many of our incumbent staff get satisfaction from doing that kind of training. It also helps the care be provided in a more holistic way. And can increase a level of satisfaction, and also just skill development for folks on staff. So I think there are things that we can be doing in the short term to make the work experience better, to develop the staff that we have on board. And we should be using each other to do that in many ways. But on a long-term basis, I think there's many things that we need to be advocating for on an ongoing basis, of getting folks in the pipeline from all settings, from all communities, so we can address some of the shortfalls we see in having folks from various backgrounds and coming from various communities to help expand our workforce and meet the needs of our changing population. So I think there's a lot that we can advise our policymakers on in terms of supporting recruiting and awareness really early in the educational program, and also in other communities when maybe some, looking at developing skill sets among some specific communities that may see this as an opportunity to grow and develop and enter the workforce in ways they might not have had available to them before. So I think we have to do a little bit of everything. But again, I think both long-term and short-term strategies that we as an organization need to be advocating for.
I think one of the things that Pat said a while back, which was looking at medical care in the home. And I think when you look out nationally and you look at things like hospital at home programs and the migration of doing more outpatient surgeries and discharging quicker, from the hospital system in general, that, this is it rises, it's connected, and it's also another layer of pressure on the community and the home environment when we're moving this very specific medical care in a much more complex way than we've ever experienced it before, out into the home, and the preferences, particularly of families when with the experience of COVID, of not trusting nursing homes. So I think all of these things, as a sort of a mega trend that's happening in California, rising above the kinds of things that we've talked about, we need to, use the master plan to talk about this mega trend of moving care into the home in a general way. I don't think it was talked about. It's much more community oriented, but not medical. But the medical is going to drive this direction, in the future, particularly with home monitoring equipment and all the other kinds of things, attributes that you can do in the home. So I think those are the things actually that we should raise within the master plan conversation, because I don't see it there in a very robust way. We're going to be caught up short. All the things we're doing is driving in the same direction, but we need to be mindful that the care that's going to be expected or is going to be impacted is also going to be at the higher end of the spectrum of complexity. So I'll leave it at that.
Well, fantastic. And I don't know, Janie or Dr. Tatum, if you have any closing remarks. If not, I know there's a couple of questions that we can turn to in the Q&A. Right, great. So just a reminder, if you do have a question, you can use that raise hand feature and we'll unmute your line to hear from you directly. Or you can always put it in chat or Q&A. We're kind of watching all of it. And so I think Elizabeth and I are going to bounce back and forth to try to get to as many questions as we can. Just highlighting that the chat was going off during the panel discussion. And so there's lots of consensus, lots of here's in there. And I will just ask the panelists if they're curious to kind of scroll through and look at those. And I, for the sake of time, we're just going to really focus in on the questions that were shared through the chat. So the first one is, and I know that we kind of referenced and talked about this throughout the discussion, but just kind of weaving it together at the end, is the general takeaway that raising wages and benefits will help the workforce shortage, or are there other challenges in recruiting and retaining the workforce? And I don't know if folks on the panel just want to kind of wrap that up, put a bow on it within a minute or two.
Yeah, I mean, I really appreciate that question. I don't think it's the end all be all. I think as Dr. Tatum said, there are other creative ways that incentivize this work that are separate just from wages and benefits. I think, from the union perspective, we are collectively bargaining wages and benefits, but to Janie's point, the transportation incentive in Santa Clara County is a huge advantage. I think the number one issue that comes up for our members when we're talking about what they want to see for the program, it is retirement. There is a huge portion of the provider population that is exempt from even receiving Social Security when they retire. And so they're, when they reach retirement age, there's potentially no retirement whatsoever that they have. So I do think that there are ways that we can be creative in attracting individuals into this workforce. But I think where we really need to start is acknowledging and ensuring that it is widely known that these are credible, skilled jobs with dignity. These are not unskilled babysitters. That is still a narrative that is out there. And I hate to say, even amongst some of our members of the legislature or elected members within local governments. And so I just think it's incredibly important that this job is seen that these jobs are seen as essential work, that the workers are valued as such. And that is a way to attract individuals into the workforce. So I appreciate that question. I think that, wages and benefits are always important, but there's more to the story. That's not the entire thing.
Thanks, Brandy. And panelists might have other reflections too, but I just wanted to highlight a comment that came in through the chat that I think childcare is another challenge. So thank you for sharing that. Anybody else want to quickly respond to the question about are there other challenges in recruiting and retaining the workforce? Okay, well, let's move to another question. And I know that we talked a lot about raising livable wages. This question is, why can't we make caregiving jobs competitive with entry-level jobs in food, retail, and logistics? If we can't, it says that we don't value the work the same way. And I think we have to ask, how do we pay competitive wages that are appropriate for skills and impact?
Well, hi, this is Dr. Tatum. I'd like to say that a lot of times people don't understand that reimbursement for healthcare entities and social entities are fixed. We're not like a retail. We can't raise our prices to match what's going on in society. If I'm an adult day healthcare, I get a flat rate per day per attendance. If I'm a nursing home administrator, I get a flat rate per day per patient. And it's fixed and it doesn't change. It doesn't change based on the fact that my RNs are now wanting $50 an hour, or my LCSWs want 50, or the PTs want 100. It doesn't matter what my daily costs are. My daily income is fixed and it will never rise. And that is why, as I mentioned before, and Brandy just alluded to, we have to be creative in the benefits and wages that we offer to people, because we cannot be competitive with retail because we don't have the luxury of increasing our reimbursements. We're paid by state and federal or other governmental entities, and they have fixed that rate, and there's nothing we can really do about it other than try to contain our costs and just try to be good stewards and managers of each dollar that we get, and try to make each dollar go farther. And I like what Brandy said. We value our people. We have them get scrubs. We buy beautiful uniforms. We give them pins and lunch pails embossed. They get badges. So they look professional and they feel good about their jobs, and we honor them. We give them certificates and awards and employees of the month. We don't, in no way do we believe that they are glorified babysitters, because they are doing an invaluable job. They're restoring and maintaining physical mobility and good health for people. And we honor that, and we stroke that ego all the time because it is worthy of that.
Thank you, Dr. Tatum. Michael, I saw that you had your hand up. Do you want to jump in and ask a question? I'm scrolling to see if I can unmute you. There you are. Go ahead, and you'll have to unmute yourself and then you can jump in.
Okay, great. So I understand, the reimbursement issue and how prices are fixed in the short run. And so I'm going to ask maybe a naive question, but is there a legislative fix to this? Is it possible that legislation would be the avenue or the channel that you would fix these reimbursement rates?
So I would offer that's a pretty complicated question, particularly, I mean, my level of knowledge is more on the nursing facility side than anything else, but there's a pretty complex funding methodology in the state of California with the reimbursement structure. I think that the biggest issue is that we're talking about Medicaid funding, and, in a very complicated structure of federal, state, and local Medicaid funds realignment. So I would say the simple answer is yes, there really can be a legislative fix to almost anything. But how that plays out when you're talking about a very defined set of money within the Medicaid pot, it just exacerbates the challenges there.
Yeah, and I understand that. I wonder if, some sort of a waiver, inclusion in a waiver application might be one way to think about addressing that. And I don't even know, I don't know the contents of the current home and community-based service waiver or the home and community, the HCBA waiver application, but is there anything in that essentially raises the reimbursement rate for home care?
This is Pat, and I think I would echo what Brandy said. It's complicated, and that's not to diminish the possibilities. I think we need to be open to all the different avenues. In terms of, I think it also bears discussion that it's not just about increasing a reimbursement rate. It's about ensuring that the money is being spent in the right places for the right things. I'm embedding that if you were to bring this issue up to DHCS or the legislators, they would start pointing to CalAIM and saying that's a way we're going to use the money we have and put some more money into it to make sure it's being spent in the right place. And I think it's up to us to kind of really dog that process and ensure that that's happening. So yes, some of the resources are finite and limited, and there certainly are areas where I would want to advocate for increased reimbursement rates, period. But I also think that we have to look at where and how those dollars are being spent. Are they being spent more on institutional care when they could be going towards support for community-based care? Are they going toward expensive institutional care as opposed to something that's more community-based, like a living situation supplemented by an ADHC type program or a CBAS program? So I think, not to muddy the waters too much, but the short answer to your question is yes. And there's a whole bunch of other stuff we should be looking at as well.
Thank you.
Thank you. What a great question, Michael. And I want to point to the chat where folks are writing about IHSS and about advocacy being a piece of this. So go ahead and check out those comments. And I know we're getting really close to time, so there's just one more question. This one is from Sheila at the YOLO Healthy Aging Alliance. The question is, the IHSS assessment is based on physical needs, but a growing number of people who have care needs are based on cognitive issues. Is there any movement to allow or include dementia or other cognitive issues to qualify for IHSS assistance? Anybody able to do that? Is that a Kathy question or Dr. Tatum?
Well, if there isn't, there should be. I've actually, at our adult day healthcare program, a lot of times if the family members disagree with their new IHSS report, they'll let my medical social worker know about it, ask for a copy of their report, and then we will go over it line for line at a team meeting that has our RN, our PT, our OT, the social worker, myself, as well as the family member, the caregiver. And we will go through the definitions IHSS gives and look at the description that the caregiver tells us of what they do on a daily basis to see if the hours match. And what I was struck with was under the section that has to do with supervision, that IHSS only recognized if a person had self-injurious behavior. So they didn't take into account that there was a blind, deaf, developmentally disabled, wheelchair-bound adult in the home that had seizure disorders and a trach and on oxygen. They didn't acknowledge that they put 0 hours of supervision for safety were needed for that individual. And I said, well, how could that be 0 hours? They said, well, we only define supervision is if a person is, they have to be trying to hit their head, elope, or commit suicide. Those were the only mental health or cognitive thing. It was the strangest answer I heard from a social worker. I said, "Are you new?" And he said, "No, I've been doing this for years." I said, "I'm not trying to be antagonistic, but I'm just flabbergasted." I said, "And I hate to sound like the lady at the department store, but I'm actually going to request that I speak to a supervisor or your manager." So we have a pending meeting with the nurse case manager for IHSS, a conference call, if you will, with the caregiver who's given permission for me to sit in on the call, because I was flabbergasted. But there should be some kind of uniform definition of addressing cognitive needs, a person with dementia. Obviously, those people would need supervision. It wouldn't be 0 hours. I was just, that was mind boggling to me. So yes, something does need to be done if there isn't.
This is Janie. I'm just absolutely stunned that that it's not. I mean, I would really like to research that for Alzheimer's dementia issues. And it comes back to the same old thing. There's a social worker and there's a social worker. And, you know, they all, I hate to say it, but you can get one that will assess one way and one that will assess another way. So we really stress how important it is to appeal those assessment when you get them, if you're not happy with them. But I do think that you can get hours for dementia and Alzheimer's. I would be just stunned if that was not the case.
Just as an aside, in other states and other assessments, because I've reviewed the assessments for personal care, dementia is part of the weighting factor.
Yeah.
Thank you all. And I know that we're about 4 minutes over time, and I want to make sure that we're respecting our panelists' other commitments today. But I just want to thank everybody for tuning into the discussion. A special thank you to our panel members for taking the time to be here and sharing their insights and wisdom on this topic. And I want to leave off with a quote that Mark Burns put into the chat as a quote from Assemblymember Ting that says, "Aging is not even among the top 10 lobbying efforts in Sacramento." So clearly there is a lot of work to do, and we look forward to working with you all as we move forward. So thank you, everybody, and I hope you enjoy the rest of your day and certainly your weekend.
Thanks, everyone. Bye-bye.
Bye-bye.